and we shall continue the race against time for students. This situation is a little different as we are nearing the university exam. The rat's liver. The topics that I am going to cover shall include pathology, medicine, or surgery. And the type of question shall be essays, short notes, multiple choice questions, or viva voce, or specimen for description. Any is possible. The first topic for the day is hemochromatosis. This literally means an excess of iron. There are two special terms. One is hemosiderosis, another is hemochromatosis. Hemosiderosis is the deposition of iron in the mononuclear phagocytic cells, such as macrophages, Kupffer cells, and bone marrow. Whereas hemochromatosis is the deposition of iron in the form of ferritin or hemosiderin in the parenchymal organs. Parenchymal organs means organs such as liver, pancreas, heart, endocrine, testis. These are the parenchymal organs. Joints also can be involved. So there are two terms, hemosiderosis and hemochromatosis. Please be clear with them. This is just a recapitulation. It may be more important under iron deficiency anemia. This is a mucosal epithelial cell, this being the luminal surface, and this is the basement membrane and the lamina propria. You find that there will be receptors for iron, and there are basically two types of iron. One is a heme ion, another is a non-heme ion. The heme ion, it passes the receptor and it traverses the basement membrane. The ferrous form and the ferric forms are being carried into the blood by means of plasma transference. It can be deposited either in the liver, metabolized, or in the erythroid marrow. And another form is the non-heme ion, which is being carried by means of the DMT and the ferroportin, etc. When it is in excess, you find this hepcidin is stimulated, which prevents further absorption. This is just an overview. There are various theories such as the mucosal block theory, etc. You people would have read it in biochemistry. And coming to the organs as such, you find that there will be about 20 to 30 milligrams of iron every day that is being absorbed and lost. So it can be stored in the liver cells or in the bone marrow, the RBCs and the macrophages. Usually about 1 to 2 milligrams is being absorbed and approximately the same amount is being lost so that there is no excess. But in some conditions, I find that there is an excess of iron that is deposited. This can be because of a defect in the membrane receptors or in the receptor ligandin complex. Defect in excretion. There will be absorption but no adequate excretion. Loss of the regulators. And finally, a free radical injury. These are all different hypotheses by which there can be an increased amount of iron. Also, there can be a genetic component such as a defect in chromosome 6, or it can be associated with HLA, human leukocyte antigen A3. Males are more commonly affected than females in the ratio of 5:1. So this is what I meant. So there can be a defect in the receptor, or there can be a defect in the negative feedback, or sometimes there can be a defect in the excretion after absorption. To put it very colloquially, this we can remember very easily. There can be an increased absorption, increased production, decreased utility, and decreased excretion. This I think we people be able to remember. Hemochromatosis is the deposition in the parenchymal organs. Now what can be the causes for hemochromatosis? I is idiopathic, most common. There can be what is called as secondary hemochromatosis. In any severe form of anemia, hemolytic anemia, ineffective erythropoiesis, where the iron is not utilized. Thalassemia, an example of a hemolytic anemia. Sideroblastic anemia. In all these things, there can be a secondary hemochromatosis. Also, liver diseases such as alcoholic cirrhosis, or sometimes it can be because of an increased amount of iron intake. It can be medicinal iron, repeated transfusions, or wine which is iron laden. So these are the various causes for hemochromatosis. I would like you people to kindly memorize this etiological table. The normal body store is about 2 to 6 grams. It can go up to 50 to 60 grams. There is a condition called as Bantu cirrhosis, and this can set off metal detectors in the airport. They say that when this patient with hemochromatosis passes through the metal detector, the alarm is set on and it starts ringing. Such is the volume. It might be an exaggeration, but we shall see towards the end whether it is true or false. One of the changes in a case of hemochromatosis will be a bronze diabetes, usually asked as a question, or if you answer, you get a mark for this. It consists of a micronodular cirrhosis, diabetes mellitus, and skin pigmentation. And there is also a pigment in the liver, a pigment cirrhosis. So these are the three. It is called a triad. And look at this one, a normal patient for control and then a hemochromatotic hand. And you can compare. There is a definite pigmentation in the skin that we can make out. Another thing that we should remember is what are all the changes in the various organs in hemochromatosis. Liver is of paramount importance. So there is a deposition of ferritin and hemosiderin, and you see the color itself, it is changing into golden brown. There is a micronodular cirrhosis, and you find that there will be more than 400 micrograms of iron. Normal is 30. Sometimes the patients can develop a hepatocellular carcinoma. So a golden brown color, micronodular cirrhosis, there can be a predisposition to hepatocellular carcinoma. And this is a histological counterpart of it. This is a normal liver, and within the parenchyma, I am finding golden brown or slightly darker brown colored pigmentation. They are usually perinuclear in location because in this region we will be finding the degenerating mitochondria, etc. When I say the brown pigment, it can be melanin, it can be lipofuscin, or it can be hemochromatosis, iron. In order to confirm, I do a special stain called the Pearl's Prussian blue, and I get a blue color in this. The Pearl's Prussian blue is a commonly asked question which you people can answer in iron deficiency in thalassemia as well as in hemochromatosis. Another organ is the pancreas. Pancreas, there are two components basically. One is the parenchyma, another will be the islet cells. There is an atrophy of the parenchyma, marked fibrosis. Islet cells will undergo atrophy also. And because of that, the patient can be developing a diabetes. Is it clear? So islet cell, no insulin, that leads to diabetes. And this is a picture of the pancreas. You see the change in the color. And here also, there is a contraction, a change in the color. This is diagrammatic. And this, as we had seen earlier, is a kind of golden brown color of the brain. Sorry, the liver. This is a picture of the pancreas. The pancreatic acini, you find that they are having deposition of iron pigmentation, and there is also an interstitial fibrosis. F is for fibrosis. Arrow points to the pigment. And there will also be atrophy of the islet cells. Three things remember. What are the other organs that are involved? Myocardium, heart. It becomes brown in color, that can be fibrosis. Whenever something is deposited in the heart, it can affect the conducting system. Therefore, the patient can go in for an arrhythmia, a cardiac arrhythmia. Sometimes there is a flabby muscle cardiomyopathy. Endocrine, adrenals is commonly affected. In the skin, apart from iron, there can be increase in melanin pigmentation also. Hemocytin pigmentation is seen in the dermal macrophages. Testis and ovary, they can undergo atrophy, and this can lead to impotence or infertility. What are the complications of hemochromatosis? I think we have covered it earlier also, but it is worth repeating. Dilated cardiomyopathy, there can be a fibrillation. Micronodular cirrhosis of the liver. Bronze diabetes, a triad, pigmentation of the skin, then there is a diabetes and a cirrhosis. Gonadal atrophy, leading to impotence or infertility. And there can be a hyperpigmentation of the skin, arthritis, strangely, carcinoma of the liver. These are some of the complications of hemochromatosis. Now look at this one. It is a person from the Bantu species. You find that there is a brown color. They say that these people brew a lot of alcohol in iron kettle and take them. Whether it is the alcohol that is causing an increased amount of absorption, or is it because of the iron kettle itself, is debatable. But these people definitely do have a hemochromatosis that is supposed to set off the metal alarms in the airports. And what can be the treatment for it and the investigations? Serum iron you look for. You find that there is an increase in the serum iron, 250 micrograms or more, and this is a normal value. Serum ferritin is also increased. Normal is about 150. Here it can be more than 500 nanograms. Transferrin saturation. It is totally saturated 100%. Normal is about 25 to 50%. Please memorize this. As I had mentioned earlier, this can be useful for iron deficiency anemia, for thalassemia, or for hemochromatosis. And one of the methods of treatment will be a bloodletting, literally. They do a phlebotomy and then there is a bloodletting. Venesection can be done. Chelators. There are some chelators for iron which can be used. And the complications, treat the complications such as fibrillation. If it is diabetes, diabetes has to be treated. So what are the lab investigations and the treatment? I hope things are clear. We are in the topic of liver. Any idea what the next one is? Any guess? I'll give you 10 seconds time. Let us start with the case history. A 9-year-old boy born to parents with a consanguineous marriage. The sibling died at the age of 7 years. And the investigations are ceruloplasmin is 4 milligrams per deciliter, Normal is about 25 to 30 milligrams per deciliter. So what is your diagnosis? The patient was found to have affection of the brain and the liver. Any idea about the diagnosis? And when a scan was performed, there was a lenticular degeneration. Lenticular degeneration was there, and there were deposits in the iron. The arrows show that. The MRI showed bilateral increased density in the globus pallidus. Come on, diagnosis. Lenticular, the word is already given. It is a Wilson's disease. Good. Autosomal recessive disorder of copper metabolism. The copper is deposited in the liver, eye, brain, and otherwise called as hepatolenticular degeneration, as these organs are affected. There is a mutation in the ATP7B gene due to the fracture of the 13q chromosome. Q is the long arm, and then there is a break in it, fragmentation. So what happens when there is a low ceruloplasmin? It leads to an increased amount of absorption. So there will be unbound copper that is there, and then it is deposited in the tissue, such as the liver, cornea, brain, and the kidneys. The unbound copper is the culprit over here, and the defect is ceruloplasmin. I gave you a history of consanguineous marriage. That means there is a genetic history in it. Please look at this diagram carefully for multiple purposes. There is a parent. It can be a father and then a mother. Both of them are carriers. You find that they have got one defective chromosome that has got the predisposition to Wilson's. But since the other is normal, they do not have any manifestation. But when they do get married, there is a possibility of all these outcomes. One, there is a normal chromosome for each of the parent, and you find that it is a normal non-carrier. Or there can be a normal chromosome from the father, but then a defective chromosome from the mother. It is still one, and the child remains to be a carrier. If it is the other way around, defect from the father but normal from the mother, it is still a carrier. But then, if there is a defective chromosome from the father and the mother as well, you find that there is a full-blown Wilson's disease and 25% chance of a sibling or rather a child developing it. This is a metabolism that it's a little difficult, but let us try to trace it. Ceruloplasmin is over there, and then it is synthesized in the liver. And it is digested by means of the enzyme ATPase. When there is going to be a defect in the enzyme ATPase, you find that there is a defective excretion of the copper. So because of the enzyme deficiency, there will be a deposition of copper which leads to Wilson's disease. And this will happen in the case of ceruloplasmin deficiency. The copper is absorbed, but then due to ceruloplasmin deficiency, this process doesn't take place and there is an excess deposition of copper. The normal copper metabolism is it is absorbed in the stomach and intestine, complex with the albumin. The free copper is transferred to the hepatocytes. Ceruloplasmin is degraded and finally excreted in the bile. This is a normal one, you people can just go through it. And these are all the various hypotheses by which it can happen. The copper fails to get converted to ceruloplasmin and it gets accumulated in the liver. It is more than the metallothionein binding capacity. And the defect is basically in the ATP7B on chromosome 13q, where there can be a fragmentation or a deletion. What are the organ changes in Wilson's disease? It can be deposited in the cornea. In the cornea, I am finding that there is a golden brown pigmentation that is there, which is called the KF ring or the Kaiser-Fleischer ring. The theories are there can be a defect in the hepatic enzymes such as ATPase. The copper is bound to the cytoplasmic proteins, or it can be because of free radicals. The other organs of deposition can be kidney, parathyroid, and so on. But please remember brain, cornea, and liver. These are the genetic basis of it. If possible, please do remember at least chromosome 13 we shall remember. And there is a particular gene in it called the apoceruloplasmin gene which can be defective. What are the organ changes? As I had mentioned, always think of the subheadings. The subheadings will take you to the answer. We had seen the mode of inheritance, what is the pathogenesis, and now we are coming to the pathology. Initially, there can be a fatty chain, then a hepatitis. The copper is in the lysosomal sacs and it can be demonstrated by means of some stains such as rhodamin and rubionic acid. And there is a reddish cytoplasm. This particular picture shows us cirrhosis. Cirrhosis, there are multiple causes, of which Wilson's disease is one. This particular nodule is appearing larger. It is a mixture of small and large. Generally, you can get a macronodular cirrhosis in Wilson's disease. And then there is the deposition of the Mallory body as well. Mallory bodies, we had seen earlier, it can be seen in biliary cirrhosis or in Wilson's disease, alcoholic liver disease, as well as in hepatocellular carcinoma. What are the complications of this Wilson's disease? Jaundice, because liver is affected, cirrhosis, we had seen. There is a liver failure, hepatolenticular degeneration, we had seen earlier. Carcinoma is possible. And the treatment will be by means of a chelator. Chelator is a substance that joins with it and excretes it. So penicillamine is one. If everything fails, then we have to go in for a liver transplant. This is a oramin rhodamin stain that is showing the deposition of copper in the hepatocytes. And what are the sequence in Wilson's disease? You find that there will be a copper accumulation finally. There is a liver injury, a liver failure, which can lead to a hepatorenal syndrome. There might be a death of the patient, or with transplant he might survive. The liver injury can also lead to a cirrhosis and ascites. And finally, there can be a biliary excretion leading to an accumulation in the tissues. Kritias tibi.